my name is Shannon Queen. I am presenting my synthesis project on the topic of interprofessional collaboration as a strategy to decrease cesarean section rates. Null pairs term singleton vertex and TSV primary cesarean delivery may be unnecessary for these low-risk pregnancies, yet the rate of cesarean births in this category are rising. The long-term risks associated with C-sections and the impact this has on future pregnancies, long-term health, and the newborn health may not be well communicated to the patient. A reduction in cesarean birth rates, particularly with the NTSV pregnancies, aligns with the U.S. Department of Health and Human Services in its Healthy People 2020 project. Through interprofessional and multidisciplinary collaboration addressing systemic inequities that contribute to rising C-section rates among low-risk pregnancies may promote a culture of change. Global C-section rates have significantly increased from 7% in 1990 to 21% today. According to the World Health Organization, the rising trend in C-sections is projected to be at 29% by 2030, which is significantly higher than the WHO's recommendation of 10 to 15% reserved for medical emergencies. What are the causative factors influencing the data, and what is the significance of high cesarean section rates? C-section delivery alters the neonatal physiology and accounts for different hormonal, physical, bacterial, and medical exposures compared with naturally occurring vaginal delivery. Infants delivered via C-section are exposed to less microorganisms responsible for boosting and preparing infant immune systems. These microorganisms are responsible for establishing the gut microbiome. According to epidemiological studies, there is a positive association between C-section deliveries and the incidence of non-communicable diseases such as asthma, food allergy, type 1 diabetes, and childhood obesity. C-section delivery affects maternal mortality, placing the woman at increased risk for early complications such as hemorrhage, resulting in hysterectomy or blood transfusions. It significantly alters future pregnancies in terms of having a repeat C-section, risk for uterine rupture, placental previa, infection, and shock, association between endometriosis with potential transformation to malignancy. Lastly, unnecessary C-sections increases health expenditures, placing a financial burden on the healthcare system. The first phase in clinical research is defining a clinical question of which my PICOT reads, in women who are presenting for a C-section, does an interprofessional case review process compared with standard practice reduce the number of C-sections performed over a 12-month period? Further clarification of population in question are women of childbearing age at greater than or equal to 37 weeks pregnant with their first singleton baby, who are presented with an option to deliver via C-section. The intervention addressed in the PICOT is a structured interprofessional case review with counseling and patient education to include the patient, obstetrician, maternal fetal medicine or neonatology, and nursing. The recommendation takes a step further than the WHO's recommendation for mandatory second opinion when delivery results in C-section. Typical mandatory second opinion occurs when the attending seeks a case review from a senior clinician in favor or opposition to the operative procedure. Implementation is compared to current standards, which rely on electronic fetal monitoring, provider convenience, and defensive medicine. Fostering a collaborative practice among professionals will reduce the number of cesarean cases and a reduction in the rates over a 12-month period. A systematic approach to query for evidence through CINAHL, Medline, PubMed, Publication Finder, Google Search, and so on, under the University of St. Augustine for Health Sciences Library database umbrella, searches were iterative to locate systematic reviews that have undergone peer review, making it pre-appraised, addressing aspects of the student's PICOT question, isolating elements of the PICOT topic, such as population. A keyword may include nulliparous or primigravida, pregnancy, and cesarean section. I utilize Boolean operators such as and, or, and not to refine and narrow a search specific to aspects of the PICOT topics. Keywords included non-clinical interventions and cesarean rates, primary cesarean births, utilizing keywords like primary C-section, mandatory second opinion, and reducing cesarean rates yielded a total of 795 articles. Application of filters further reduced that number to 528, and then listing any articles published in the last 5 years reduced to 255 sources. Excluding words such as mechanical breastfeeding infection reduced the sources to 13. A study by Niyakunze 2025 concluded in a pre and post intervention study into a hospital with cesarean delivery rate of 52.9%, that mandatory second opinion alone did not drive down cesarean rates. The study reveals a high incidence of patient preference for primary cesarean sections, which indicated that to this student the need for interprofessional patient education and further collaboration teamwork to change the culture towards support and safety of vaginal births. 3 studies satisfy the topic-related data search for the evidence-based question of collaborative teamwork to reduce rising cesarean delivery rates. Of these 3, 2 were a cluster randomized controlled trials, one conducted in Latin America, which informed subsequent World Health Organization recommendations aimed at reducing unnecessary C-sections through non-clinical measures. The definition of a mandatory second opinion encompasses a peer-to-peer consultation with a secondary clinician being of senior status, which is evident in all 3 studies. The lastly being a pre- and post-evidence summary of implementing mandatory second opinion, and it did not greatly reduce the rising C-section rates, but peer-to-peer consultation provides supportive decision-making and perhaps allays fear of litigation, the reinforcement of evidence-based practice, and sound clinical judgment in the promotion of health and safety. However, mandatory second opinion is a change happening in a silo. Flexibility is key during the synthesis stage, and it becomes necessary to reanalyze evidence from a different perspective to have a true and complex understanding. Evidence synthesis is the process of combining 2 or more elements to create a new idea or understanding with the whole being greater than the sum of its parts. This is by Bissett et al. 2025, page 139. The overall picture generated a new insight understanding, and that in order to reduce cesarean delivery rates, a multifaceted approach deeply rooted in healthcare culture change is the answer. Synthesis of evidence themes have generated new insights and understanding on how to implement best evidence recommendations. Mandatory second opinion is a linear approach to reduction of cesarean deliveries. The method is isolated within a clinical discipline and limits the development of other possible perspectives for evolutionary change. Positive themes include real-time clinical action, which leads to communication clarity and actionable tasks that may avoid a cesarean delivery. The Robinson classification or 10-group classification system is a World Health Organization tool that divides all deliveries into 10 groups based on simple obstetric factors, parity, previous C-sections, or fetal presentation, to help hospitals audit, monitor, and reduce unnecessary C-sections by identifying which patient groups contribute most to the overall rate, allowing for targeted quality improvement. It standardizes data, making C-section rates comparable, pinpointing areas needing better practices, like reducing inductions or managing previous scars. Tools such as the Robson classification and the Bishop score will aid clinical teamlets in a plan of care. Bishop scores help to decide when to induce labor, and Robinson classification assists in understanding why interventions happen after induction. Standardizing policies improves quality, reliability, compliance, and efficiency when multidisciplinary team members know and expect what might occur in line with protocol. Changing culture to prioritize vaginal birth requires strong political commitment, strategic planning, stressing the importance of high-quality regulation and education in line with international standards, and supporting autonomous evidence-based practice. Childbirth is increasingly medicalized. Giving increased repeat C-section delivery rates, patients should be informed that the risk of placental previa, placental accreta spectrum, and gravid hysterectomy increases with each subsequent cesarean delivery, and nursing is leading the change towards a patient-centric model of labor and delivery. The setting for the plan change. Plan of care huddles, multidisciplinary rounds or MDR, and interdisciplinary collaboratives are central to the team birth model. All members of the clinical team, a nurse educator, nurse manager, clinical nurses, obstetrics, maternal fetal medicine, neonatology, and so on, meet with the patient giving birth and their support person upon admission to the labor and delivery unit and at regular intervals. This approach ensures that the team understands the patient's preferences and condition and can establish clear expectations. Utilizing standardized tools such as the Bishop scoring and the Robinson criteria allows for the patient participation and understanding during the labor progression. Elective cesarean deliveries are in part due to the fear of pain in childbirth. Team birth has shown to provide the patient with a person-centered supportive approach to labor. Supportive care by all team member measures addresses pain relief and ensuring the safety of the mother and newborn. Collective involvement bolsters the physiological process of birth and a culture to support women in vaginal delivery of the newborn. It restores the dignity and autonomy of the patient in self and maternal care. Interprofessional collaborative or team birth approach builds a cadre of experts equipped to provide individualized, respectful patient care, ensuring the patient is a constant part of the decision-making process and has real-time understanding and information she needs, as well as the emotional support during labor. Within a team-based culture supportive of vaginal births, patients will be provided with consistent and succinct education to inform decision-making. At this stage in the PICOT intervention research, many recommendations have been made for non-clinical implementation. Organizations already discussed have postulated that mandatory second opinion be utilized as a strategy to reduce unnecessary C-section rates. Nursing has a voice in satisfying what remains to be the fact that, by and large, nursing is responsible for patient education, providing comfort, safety, quality, and patient satisfaction during labor. It stands to reason that interprofessional collaboration should include nursing. Nursing is an essential part of the labor team, who are responsible for internal and external fetal monitoring and interpretation, vital sign monitoring, vaginal exams, and reposition to elicit change in fetal rhythm when warranted. Plan of care huddles or multidisciplinary rounds are daily meetings with the patient at the bedside to discuss daily goals or objectives of potential situations or concerns to create a clear and collaborative plan of action. The use of this model supports mandatory second opinion for the indication of cesarean birth, with more supportive roles joining the dynamic conversation. Working towards a clinical model, it may present as something incorporating a Robinson classification into a patient labor plan and a deviation action format plan with a primary focus to support spontaneous vaginal delivery, utilizing current and other evidence-based assessment tools and guidelines. Evaluation metrics are identified as collaborative efforts of all interprofessional team members, equal engagement and participation, utilization of well-established labor management tools such as Bishop scores and Robinson criteria as previously discussed. Additionally, all participants have the understanding and agree upon the plan of care, especially the patients. The patient may ask questions and clarify medical terms and jargon. Nursing staff have a direct one-on-one contact with the patients. Nursing is a critical point of contact for education and a person who is setting the tone for a woman's labor experience. Nurses explain complex information during a vulnerable time, which is why interprofessional collaboration is so important for the overall support, quality, safety, and satisfaction of the patient. Organizations having 300 or more births annually report cesarean rates to entities such as Leapfrog, which provides individualized scores as well as overall state scores. In 2024, Florida's average nulparous or NTSV C-section rate is 27.2%, exceeding the Leapfrog standard of 23.6%, and the World Health Organization's goal of 10 to 15%. Current with C-section birth rates are compared with future 2026 rates based on the time of implementation of strategies to reduce this birth method. Data collection and analysis would include both quantitative and qualitative information, such as the Robinson classification and electronic health record audits, qualitative in the form of patient and provider experiences. To analyze this information, we'd be using the chi-square test to compare periods of success or failure rates pre and post implementation of the interventional collaboration. For the dissemination plan, I would employ the TRIP model, including the implementation of the 4 E's, the engage, educate, execute, and evaluate. Interprofessional collaboration is a valid intervention for primary C-section delivery reduction rates. The solution is multifaceted and holistic in its approach. Obstetrician providers consult laterally with maternal fetal medicine or neonatology who educate parents on the risk of the cesarean birth. Nursing is supported and invited to an action plan that supports vaginal delivery, and deviations to that plan are recognized early in the laboring process. Quality, safety, and patient satisfaction themes resonate through the culture change. Investment in culture change takes time, effort, and a desire to make a difference through education, and in turn, educate patients on optimizing the labor experience. Thank you for your time. The following slides are references used in this format. The following slides are references used in this format. The following slides are references used in this format. The following slides are references used in this format.